My name's Steve Powis. I'm the National Medical Director of the NHS in England, and the reason I am here today is because I am the SRO for the Human Health workstream of the government's 5-year National Action Plan on antimicrobial resistance. But before I get on to that, I'd first like to reiterate David's thanks to you all. So I know how hard all our infection prevention and control teams and staff involved in IPC, in hospitals, in community and care homes, and throughout NHS and social care work on this area. So a huge thanks for all the work you have done, and a particular thanks because I know many of you will be working on preparations for a potential upswing in cases of the new coronavirus, and if you're not working on it already, I'm sure you will be working on it over the next days and weeks as the NHS stands up its preparation for a possible epidemic if that occurs, and of course it's an if at the moment rather than a when. The NHS is well prepared and well used to managing these sorts of things, and as you would expect, NHS England, NHS Improvement, in close collaboration with PHE and Department of Health and Social Care and the rest of government, is already working on this. IPC plays a big part of that. The programme is being led currently by my colleague Keith Willett through national and regional EPRR teams, but Linda and the IPC team are heavily involved in those preparations, which of course is a multi-stranded preparation. So a huge thanks to all of you who I'm sure are already thinking about this, but I'm sure we'll be working on it over the next weeks, days and months. So I've been asked to talk about the AMR long-term plan commitments, but the AMR long-term plan commitments really mirror the commitments in the National Action Plan. And so long-term plan was published a year ago, the action plan was published a year ago, and so we absolutely wanted to make sure that there was alignment between what we said about AMR and infection control in the long-term, infection prevention and control in the long-term plan and the AMR action plan. And because they were both aligned in terms of timing, we were able to do that. And it was really important to me personally that we got this as a core component of the long-term plan. So the second thing I'd say is that AMR and IPC are really, to me, just two sides of the same coin. And I know we have the conference here with infection prevention at the top and AMR in smaller print underneath, but increasingly we are working on this through the lens of AMR. So you will often hear us at NHS England talk about antimicrobial resistance, but infection prevention and control is a key part of that programme and strategy. And of course, the simplest way to manage antimicrobial resistance is to prevent infections in the first place, and therefore antibiotics don't need to be used or manage infections correctly. So the first point I would emphasize is to me these are so closely integrated that when you talk about one, you talk about the other. The second to say is that we are really focusing in the National Action Plan on a few specific ambitions, and those ambitions are listed here down the right-hand side. So the first is to reduce resistant infections by 10%, and that's really the headline measure. The measures underneath that will drive that are a particular focus on gram-negative bloodstream infections, which I'm sure you're all aware of. I'll say a little bit more about. A reduction in the use of antibiotics by 15% overall, 25% in the community, and 10% reserve and watch in hospitals, and then increasingly being able to report on the percentage of prescriptions and the details of prescriptions used. So those are the key targets and the ambitions, and you'll see on the other side a sort of summary of how we're doing. So antibiotic prescribing in primary care, I think we've actually been doing reasonably well on. So between 2013 and 18, we have seen a 13% reduction. We clearly need to do more work, but I think we have made good progress. Where we are doing less well is antibiotic prescribing in secondary care. And in a sense, on use of antibiotics, we now need to keep the focus on primary care, but we increasingly need to shift the focus into secondary care as well. In terms of bloodstream infections, we are continuing to see an increase in gram-negative bloodstream infections. We are not seeing it at the rate that we think we would have seen it if we hadn't taken a variety of actions, but we are nevertheless still seeing an increase. And therefore the challenge, the ambition to halve gram-negative bloodstream infections is a really tough challenge in one sense. And therefore the decision of NHS England, NHS Improvement to introduce targets at individual trust level from April this year as a start to reduce gram-negative bacteremias in hospitals is a really important step that I'll say a little bit about. But of course, many more gram-negative bacteremias, bloodstream infections occur in the community. And so it's not just about focusing on hospitals, it's also about focusing on the community. And the community in one sense is a harder setting. We have well-established infection prevention control teams in hospitals. We know how to do this. We've done it on MRSA, we've done it with C. difficile. Community and primary care settings are a bit different. They are more variable in terms of their IPC support, and they're more variable in the way they're structured, and I'll say a little bit about that too. Those are the headlines in terms of what we are trying to achieve. The sort of how we're going to do this and how we're going to engage you down from national level through regional level into integrated care systems is sort of described here, but I'll just make a few points about it. So we have set up a team at NHS England in order to drive this programme. It sits under Karen Turner, who is the Director of Prevention in my directorate at NHS England, NHS Improvement. Karen will be leaving, unfortunately, soon, but we will be continuing with her replacement in driving that programme forward. And we are building that team over the course of the next year to be able to support all of you in delivering this programme. It's not just the work of Karen and the team that will drive this. We work very closely with a number of other teams. I've mentioned the IPC team at NHS England and the NHS Improvement, Linda and Ruth May, and we work very closely, but we also work closely with Keith Ridge, the Chief Pharmaceutical Officer for England, and Keith is really important. He drives the prescribing ambitions with colleagues in the pharmacy part of NHS England. And then finally, Sue Hill, who is the Chief Scientific Officer, drives a lot of the diagnostic work that I'll mention. And then, of course, we work very closely with colleagues on this, so PHE in particular, and Susan Hopkins at PHE works very closely, and it's Susan who will be driving the work with our team in setting the ambitions for hospital reduction in gram-negative bloodstream infections over the next year, and that's in flight at the moment, and you may be having those conversations as we speak. There's a bunch of other programs at NHS England that are listed there that we will increasingly use to drive these programs, such as the Getting It Right First Time program and the Medicines Value program. I'll say a little bit about primary care networks later, but increasingly we are moving to a delivery method which is based around integrated care systems. And so as integrated care systems develop, I think it will be really important that we start to place the AMR agenda and the IPC agenda within the integrated care system setting, because that's the opportunity to drive what we all know we need to do, which is the joined up care and the joined up approach between secondary care, primary care and social care in order to drive this agenda forward. So I've certainly visited a number of ICS-based IPC programs over the last year, and I can see the work that's being done. I can see how those links are being made. And I guess one of my pleas to you today is to use the development of ICSs, I'll say a little bit about primary care networks in a minute, to drive this agenda. Now, we do have some funding centrally for this program, and it's not huge amounts of money, but it's enough to get us started on a central program. Of course, a lot of the work goes on locally, so that I know there's a lot of funding and a lot of resource other than this in the system. But we are setting up a central team and a regional team as well, because actually we want this to be delivered through regions as much as possible. So that's all in train at the moment. I won't give you the details, but just to say that we are beginning to put that in place to provide the support that you will all need. Now, of course, there's a huge return on investment on this, because we know the cost of for instance, gram-negative bacteremia, so E. coli bloodstream infections are shown there as an example. When it comes to driving business cases and use of resources locally, we can help, and I'm sure you can help yourselves in terms of persuading that this is not just about good care. Of course, it's about good care, and it's about the global threat of antimicrobial resistance, but there is also a financial benefit as well in terms of savings to the system. So it's always important to keep that in mind. Now, in the last few minutes, I just wanted to make some key points in the programs, the various strands of the program, the AMR program for the next year or so. And I'm going to whiz through this. I'm sure during the course of the conference there will be the opportunity to talk about some of these areas in depth. Optimizing prescribing, there's our objectives and the next steps, and the one I really wanted to highlight was primary care networks. So I'm sure you're aware primary care networks were established just under a year ago, and they are bringing together of primary care, typically to serve populations of around 30 to 50,000. They are not organizations in their own, they're collaborations formed in a variety of ways. But the underlying thesis behind them, or the underlying ambition, is to drive primary care more at scale, and also to allow the deployment of an additional primary care workforce. So 26,000 new staff in primary care, including many pharmacists. Including in this primary care networks are a set of service specifications. First of those were agreed by the BMA only last week and are implemented from April 2021. And some of those, for instance, include optimizing prescribing. So there is a resource in there, a particular resource of pharmacists going into primary care networks. And so I think there is an opportunity to have a conversation with primary care, and each of those PCNs have clinical directors. They will be busy because they're setting them up. They're busy because they've got a lot of setup to do, a lot of staff to recruit. But part of the conversation I think you need to have with them in the context of integrated care is how that new resource that is going into primary care can be used on the antimicrobial resistance agenda and infection prevention and control. So I would urge you to think about that in the next day or two and as you go back home. The big ticket item, I guess, for next year for us is the introduction of gram-negative bloodstream infection targets in April. So we put this in the consultation for the standard contract that we use at the end of December, and we will be introducing this from April. The work, as I said, is ongoing at the moment. We are starting off with a reduction of around 3 to 5%. That will be set individually for individual trusts. Now, I'm really confident that we can do this because certainly when I was a medical director of an acute trust, and it's not so many years ago when I was, I saw the transformation over a decade from not believing collectively that we could do anything about MRSA bacteremias to a complete cultural change to where we were shocked when we got one. And it's all you in the room and colleagues not in the room who drove that operational and cultural change. And we have done the same with C. difficile. And the teams and the structures that did that still exist in our hospitals. So the next challenge, and I've always had the sense that you all want to go to a next challenge, is gram-negative bloodstream infections, because this is one of the biggest drivers of antimicrobial resistance. And certainly we've been collecting the data. I know you've been collecting the data on this. but we have not as yet set ambitions for individual organisations. So we want to do that. We want to do that in a very supportive measure. This is not about financial penalties. In fact, we're removing financial penalties for C. diff and MRSA. This is really around improvement in infection prevention and control. And as NHS England NHS improvement moves much more to a focus on improvement rather than assurance, we want this to sit within the improvement agenda. But I'm really confident that this is something that we can do. And if we get this right, it will start to deliver that ambition for a 50% reduction. In doing this, we will be asking you to work closely with your colleagues in the community. And I know that can be challenging. I've been there myself. But we are in an environment now where the system is increasingly driving towards collaborative working, as I've said, for integrated care systems. So my hope and expectation is that this joined up work that will also be part of this will be easier to do than it's been in the past. So, as I've said, we're looking at the range of 3 to 5%. I know Susan and the team are working with organisations as we do this. Next year, the first year, we will clearly learn a lot about our ability to do this, and then that will drive into what we need to do in future years. So thank you, everybody, for that are involved in hospitals and the hospital setting for taking this on and for working on it over the forthcoming year. I'm not going to say a lot about AMR Diagnostics. You can see the objectives and you can see the next steps, but this is a really core part of what we do, and Sue Hill, the Chief Scientific Officer, drives this particular part of the programme. Sepsis. Again, I'm not going to talk a lot about sepsis, but sepsis is one of those areas where there is a tension between the overuse or the inappropriate use of antibiotics, or I should probably phrase that, getting the antibiotic usage completely right, and not missing sepsis. So I see both of those. With one hat on, I see the consequences of when sepsis is missed. I see coroner's reports, I see information from the system. With my AMR hat on, I see the dangers of overprescribing for sepsis. So it's really important that we get that balance right. And one thing that I might highlight in terms of the approach to that, yet with another hat on, I'm currently undertaking a review for the Prime Minister of the key access targets that we use in the NHS. One of those is the A&E 4-hour target. We published an interim report last year which suggested some alternatives which are currently being tested. One of those is a standard around management of deteriorating patients, including sepsis. And we are live testing that at the moment in a number of our pilot sites. And what we are focusing on in that standard is rapidity of senior decision maker. So we've deliberately not said we are going to, once a patient with a particular news score, a particular level of deterioration is identified, that automatically leads to the deployment of antibiotics, because that would be the inappropriate thing to do. What we have said is that what we need is a senior decision maker to assess the patient and make the right choice. So it's those sort of subtle differences in the approach that we take to this that I think will get that balance between treating sepsis, identifying and treating it appropriately, and not treating deteriorating patients inappropriately when sepsis is considered but is actually not the diagnosis. Final few points from me. Actually, let me go back a few, because there was one other one that I wanted to mention, which was around community infections. And so that's probably in the second bottom one. So I said earlier that we needed to focus on community. And I think one of the big areas of focus needs to be care homes. And I know some of you here today are from care home settings. And I think the approach that we're broadly going to have to take to AMR over the next few years is probably just 4 or 5 key, very targeted efforts in particular areas, of which Gram-negative reduction in hospitals is one. And I think in care home settings in particular, but not just, catheter management and hydration are 2 really important focuses of work. Again, in the GP contract, part of the GP contract is around putting more general practice and primary care into care homes. And so I think there is opportunity through primary care networks to take that agenda forward, but it can't just be that. And so we're working quite hard at the moment to think about what the correct targeted approach would be in the community setting. Just a quick note that Dame Sally, who you saw in the very first slide, was very keen with others that we look to see how we could incentivize drug companies to develop new antibiotics. So one of the problems that we have at the moment is disinvestment of companies in new antibiotics. And we are piloting commercial models with NICE that we might use in collaboration with the pharmaceutical industry to try and drive forward development of new antimicrobial resistance. This is an important strand of the work. I'm not going to talk about it. It's complex work, but it's just to note that that is going on. Data is really important in all of this, and Susan Hopkins leads the data work stream. I should say that in England we have good data, but in devolved administrations, if anybody's here from the Scotland, Wales, Northern Ireland, they are a little bit further behind in data collection. They're getting up to speed, but the AMR agenda is a four nations agenda, so it's important that we work closely with our colleagues in devolved administrations. I think one of the key things in hospitals that will drive better data is the introduction of electronic prescribing. So a big part of this program, which is not in the program but is in NHS X and NHS Digital, is to drive the uptake and implementation of electronic prescribing systems. There's a huge variation in their deployment at the moment. But equally, I would like to see work on how we best use electronic prescribing systems to drive forward both infection prevention control and in particular the AMR agenda. So if any of you are interested in that, then we'd be interested in talking to you too, but that's a key part of this. And then this very last slide, so I'll finish off with this, which is to go back to integrated care systems and SDP. So I've visited integrated care systems in Kent, in Cumbria, and in Cornwall, which are three pilot ICSs that have been working on this. I've been back to Cornwall and Kent a couple of times, and I've been really impressed with the progress that's being made there. And it really gives me confidence that we can bring together AMR and infection prevention control out of the silos of hospital, community and primary care into a much more joined up approach, and that's what we will need to do to meet these ambitions.